personal question to you, Bradley. What would you use if it was you or a loved one, family member with neuropathic pain? Which one would you choose for them?
That's a good question, Nick, because...
So you'd give that to yourself?
Yes.
Done. I would do exactly the same thing, funnily enough, and you and I have not discussed this before. I had a patient with ear pain. I know we've discussed this at our consultant meeting. So she had neuropathic ear pain. Lovely lady, absolutely broken by the pain. And welcome back, everyone. This is the Pain Diaries podcast, where we unpack the realities of living with chronic pain, one story, one expert, and one honest conversation at a time. A patient said to me recently, my doctor keeps on prescribing all these medications, but none of them work. And that got me thinking. So today we're going to discuss neuropathic pain and medications used for neuropathic pain. As always, I have my trusted colleague with me, Dr. Bradley Lewinsohn. He is a pain specialist, he is an anaesthetist, he is a friend and a colleague. Welcome, Bradley.
Hi, Nick. How are you going?
Good, thanks. What I want to do today is I want to dive into the medications that we use for neuropathic pain, and I think we should do it three ways. One is we'll touch on neuropathic pain, what it is, and then we'll just dive into the medications and break down some of the medications for those listening. How does that sound?
That sounds fantastic. And this is something that we're doing for education for our patients. We just want to let everybody know out there that this is not medical advice specific for you, and to always touch base with a medical professional before starting any treatments.
Sounds good. All right, well, let's dive in. Bradley, you're a pain expert. I know because you and I have just had a discussion about the many years that we've actually been practicing medicine and pain. So for your information out there, this clinic has treated more than 22,000 patients since its inception 10 years ago. I have been managing, or Bradley and I have been managing pain for a total of 40 years combined between the two of us, and for a total of 29 years managing chronic pain. So we've got a bit of experience in assessing, diagnosing, and managing pain. Would you agree with that?
Yes, we've been doing this for a little while, maybe longer than I want to admit to, but we've been in the game for a bit of time over here.
All right. Tell me, let's talk about neuropathic pain. Tell me a little bit about what neuropathic pain is.
So neuropathic pain is primarily a pain that's generated by the nervous system. And it's difficult for patients because we like to give pain labels from different aspects, don't we, Nick? We'll call it a neuropathic pain, a nociceptive pain, a visceral pain, or a mixed pain. But primarily, neuropathic pain, it has some unique qualities to it that can increase a patient's suffering. And that tends to be typical descriptors that patients may use for the pain. So burning, tingling, numbness. And with nerve pain, it tends to be mostly exacerbated at nighttime and can be activity related as well. What causes neuropathic pain?
There are many causes of neuropathic pain. Generally, by definition, it is a lesion or a disease or something that affects the nervous system. So the central nervous system, the brain and the spinal cord, or the peripheral nervous system. The big ones that we see in our clinic are medical causes, such as surgery, so trauma to the body via an injury, trauma to the body via a surgery. So surgically induced neuropathic pain is a big one. It's called post-surgery neuropathic pain or post-surgical chronic pain. Medical conditions like diabetic neuropathy, infections like shingles, a lot of spinal degeneration that causes neuropathic pain. So compression of a nerve within the spine, compression of a nerve somewhere out in the body. Medications like cancer medications cause peripheral neuropathy. So there are many causes of neuropathic pain. How do you diagnose neuropathic pain, Bradley?
Well, It would be nice if we had a simple blood test that we could take that would tell us that patients had neuropathic pain. Unfortunately, nothing like that exists at this time. So we have to go back to our tried and tested methods of using clinical examination and a clinical history, and combined with a questionnaire that we usually get to fill in with patients to give them a neuropathic pain score. There's a few questionnaires out there that have been validated in the research papers. So there's the Leeds Neuropathic Pain Scoring Questionnaires, the DN4, or Pain Detect scoring system. And these basically ask simple questions to a patient, and they're rated on a numerical scale to give an overall probability of the pain being neuropathic.
So it's what the patient says: burning, tingling, pins and needles. You know, the question that I ask the patients, the single question that I ask the patients that gives me quite a good feel for whether they've got neuropathic pain. What would that be? Or what do you say?
I imagine sleep.
Sleep. Exactly right. Does the pain bother you in bed at night when you're not doing anything, when you're not moving? Because, of course, spinal pain, facet joint pain, mechanical pain is a completely different pain, and neuropathic pain is not that. Neuropathic pain has its own features. So when I examine somebody and you examine them, you push on their back or you push on various parts of their body, and then they walk over from the table to the chair. By the time they've got to the chair, it's hurting. So there's that delayed onset of pain. There are those aftershocks or after sensations that patients get as well. It's like you've said, pain on light touch, pain on a brush. We use a toothpick. That's the most complex piece of equipment I've got in my office. And you compare what a toothpick feels like on a normal part of the body to the pain area, and it's much more painful in the pain area. That's called hyperalgesia, and that is excessive pain. And allodynia is pain to light touch. So a patient comes to you and says, I've been given all these medications, nothing is working. Why do paracetamol, why do Brufen, why do these medications not work for neuropathic pain?
Well, unfortunately, paracetamol is a fantastic drug, and ibuprofen, although it has some issues, is also a fantastic drug. But these drugs don't tend to be working primarily on the nervous system. They work within the tissues, reducing inflammation, and so they're much better suited for musculoskeletal pains, i.e. a joint pain and a muscle pain. They're not the appropriate drugs to use in these neuropathic pain syndromes. And what we have to do is we have to use the right drugs for the neuropathic pain.
Excellent.
The question is, what are the right drugs for the neuropathic?
So what are the right drugs? Let's dive in. So you've got to make the diagnosis. And if you don't make the diagnosis, it's always the same. I say to people, when people ask me, I want to do this and this and this for a patient, I say, well, what's the diagnosis? You've got to have a diagnosis first. Otherwise, it's pointless treating them. So there are 3 tiers of medications, or 3 steps of medications that we use for neuropathic pain according to the research. And I will put the research down below so you can have a look at these papers for yourself. Let's talk about the first line of medications. And there are 3 groups of medications in the first step to treat neuropathic pain. The big one are the Gabapentinoids, which I'm sure listeners would have heard about. They would have either given something called Pregabalin or Gabapentin. Bradley, I want you to tell me a little bit about these medications, how they work, what they do to people, what side effects they have, and which one you would choose.
Nick, these medications, we have to make our audience members all aware, they haven't been primarily designed to treat neuropathic pain. What's happened is we've been using these medications for other conditions, and then we found out along the way that patients' neuropathic pain improves, and we've done some studies, and we've shown an effect with these medications in nerve pain conditions. So they generally tend to be medications purposed elsewhere that we've taken on board to help treat neuropathic pain. So the Gabapentinoids, they're originally anti-epileptic drugs, and I have to tell my patients, I'm going to give you an anti-epileptic drug. I'm not diagnosing you with epilepsy or treating your epilepsy. I'm using this to treat your nerve pain. And that the way they work is through binding onto a receptor called the alpha 2 delta ligand and causing the cell to become less excitable. And so that's how they tend to work in the body. We start patients, in my opinion, on low doses of these medications and slowly wind it up to try and find that optimal dose range. Because with every medication, even from the most indolent medications to the most complex, there's going to be a whole host of side effects. And with the gabapentinoids, it tends to be sedation because we're turning off the nerve fibers, and we're trying to turn off specific nerve fibers, but we'll turn off nerve fibers all over the body. And then the typical side effects of turning off those nerve fibers tends to be sleepiness, which then comes with cognition problems, i.e. memory problems, changes in mood, and then abdominal bloating, and the typical side effects that you can get with a whole host of other medications, including nausea, rash, and weight gain.
So weight gain. Patients always ask about weight gain. Clearly, it's an important factor. Do they cause weight gain, gabapentinoids?
They can do, unfortunately, and it can cause weight gain in a small subsection of patients. The problem is they tend to be a good medication to start with. And if they do cause significant weight gain, we can always take patients off the medication. And the weight gain tends to be initially fluid retention in the beginning rather than actual fat tissue.
Which one of these two medications do you use as first line if appropriate, and why?
So I don't know about you, Nick, but I tend to use gabapentin as a first line medication. And the reason that I use gabapentin is because it's got this very nice dosing schedule where you can use small amounts of the medication and build it up. And gabapentin usually goes from a dose of 100 milligrams 3 times a day up to 1200 milligrams. So that's a huge 12-step increase that you can use gabapentin to fine-tune it for your nerve pain.
So I use gabapentin preferentially as well. I think it causes much less weight gain than Lyrica. I cannot remember when I last prescribed Lyrica. There's a concern with Pregabalin that it can affect your mood, can't it? And there is a black box warning that it can detrimentally affect your mood. So I've certainly had some people where I've prescribed some gabapentinoids and it has affected their mood. I steer clear from Pregabalin for this reason, and I find that gabapentin is much better tolerated. Okay, so we're both a tick for gabapentin over Pregabalin. Again, this is an opinion of two doctors, experienced doctors, but nevertheless an opinion. Right, let's move on. We're still on the first step. Now we've talked about weight gain, which is a big factor. I tend to use a lot of a chemical group called the SNRIs, which is the serotonin or adrenaline reuptake inhibitors, because they are non-sedating, so they work quite well with a gabapentinoid, and they don't cause weight gain. Break down the SNRIs for me. Do you use them? Who do you use them on?
Yes, I use SNRIs. There tends to be 2 types of validated SNRIs. When I say validated, I mean having research studies with evidence to show that these drugs will help patients reduce their pain by 50% or more. The 2 medications that I tend to use are duloxetine or Cymbalta and venlafaxine, although I tend to get slightly more side effects in patients with venlafaxine than duloxetine.
Okay.
And I'll start off with duloxetine. Duloxetine is an antidepressant medication, and so obviously if patients are already in antidepressants, I'll choose to steer clear of them. But if you can, it is a nice option for patients with nerve pain.
What do patients say to you when you say to them, I want to give you this medication? It is an antidepressant, because we've got to be honest with people we treat, of course. Do a lot of people say, yeah, that's okay, that's fine, sign me up for an antidepressant?
Not always. Some patient preference may be not to have an antidepressant
Yeah,
for various reasons. They may have had antidepressants in the past and really not want to be prescribed this class of medication again. Or some patients may feel that there's a stigma attached to being on an antidepressant to a certain degree and not want that medication for that reason.
correct. And it's there for pain control. It is not there for mood. If your mood happens to be up and down, it might have a beneficial effect on your mood, but it is not there. We're not using it for your mood primarily. So the third group of medications in this first step of treatments are the older antidepressants, the so-called tricyclic antidepressants. Amitriptyline is one, nortriptyline, imipramine. There are a whole bunch of others as well. Give me your views on the tricyclic antidepressants. How would you use them, and what would you use?
So the tricyclic antidepressants, again, validated treatments for nerve pain. So they have research studies behind them. The one that has the most is amitriptyline because it tends to be the oldest. There's also some good evidence for nortriptyline. Amitriptyline and nortriptyline tend to be the ones I use the most, and nortriptyline tends to be better tolerated in patients. So a lot of the times I may stick to nortriptyline, or actually sometimes I may try to use the older one, the amitriptyline.
Okay. Well, we see a lot of complex pain in our clinic, of course, because we're a big clinic, we're a well-regarded clinic. We see a lot of people that have had pain for a long time. So generally, these people have tried amitriptylines and the pregabalins. When do you use amitriptyline over nortriptyline?
Amitriptyline has a side effect of a sedative side effect. And so in patients with nerve pain who cannot sleep at night, a small dose of amitriptyline may be helpful for restoring their natural sleep cycle and actually helping to treat their pain. And the sleep will happen earlier. The pain relief will take generally 2 to 4 weeks to kick in. And then I can slowly increase this medication. There may be a hangover effect with amitriptyline, which is why patients don't tend to tolerate it and continue it, where they wake up in the morning still very sedated and drowsy. That generally tends to fall away in the patients that are going to be able to use this medication within about 3 to 4 days. But if patients can't tolerate for the sedation side effects and a bit of the dry mouth side effects, I might choose nortriptyline, where these side effects are less prominent.
Yeah, I far again prefer nortriptyline because most people have tried amitriptyline. They don't like it. It's a thick, heavy, sluggish medication. If they're getting side effects, if you're getting side effects early in the morning, take the medications earlier in the evening so they can adjust the medications, adjust the way they use these medications. So we've done the first line of therapies. Personal question to you, Bradley. What would you use if it was you or a loved one, family member with neuropathic pain? Which one would you choose for them?
That's a good question, Nick, because every time we choose a medication, it needs to be based upon the patient that you see in front of you. What medication are they already on? Do they have any medical health conditions? That means that you may choose one medication over the other due to either interactions with the medications that they're taking or their conditions that they have. Uh, in general, I tend to start with something like gabapentin because it crosses all bases, and then if that wasn't appropriate, I may move on to something like duloxetine.
So you'd give that to yourself.
Yes.
Done. I would do exactly the same thing, funnily enough, and you and I have not discussed this before, but I would use an SNRI, absolutely, because it's non-sedating. The desvenlafaxine is probably a little bit more gentle than the duloxetine, but duloxetine probably works a bit better, and nortriptyline if sleep is a problem. And if sleep is not a problem and you're taking the nortriptyline, you can even take it in the morning, can't you?
Yes.
Certainly got people that take it in the morning.
Take a small dose in the morning if it's not making you sedated, and it can help
Good.
to cover you for that 24-hour period.
All right, we've done the first line. Let's move on to the second line or the second tier of medications, and there are two groups. Tramadol, Tapentadol as one group, and then the topical agents, the lidocaine patches and capsaicin cream. Break down Tramadol and Tapentadol for me. Which one would you use and why?
The one that doesn't cause side effects.
They all cause side effects.
And that's the issue with these medications is that you might go for Tramadol first before Tapentadol, depending if they're again what medications they're taking. Because if they're on antidepressants, Tramadol can interact with antidepressants. And you may try and steer away from Tramadol because if you know that if you're going to give it to the patient, there's a high likelihood it's going to make them feel unwell, and you may move to something like Tapentadol instead. But Tramadol is nice because it doesn't have a lot of strong opioid activity, and so we tend to use the prevailing thinking Tramadol first and then Tapentadol after that because it's got a bit of stronger morphine-like properties to it.
I think Tramadol had got a bad rap in Australia because of that paper many years ago about the serotonin syndrome and the serotonin interactions. Both Tramadol and Tapentadol can affect serotonin levels, so they can go up and they can interact with other serotonin medications. What do you tell patients about the possibility of serotonin issues? Do you talk about that? And if you do, what do you tell them?
Well, yeah, I do talk about it. And what I tend to say is that these medications, as with all medications, can interact with each other and cause a syndrome. It's uncommon. So it's not every patient that takes these medications together will get this syndrome. And if you do start to get it, you will get side effects, which tend to be nausea, racing heartbeat, and sweating. And, we need to discontinue the medication.
So out of all the decades that you've been practicing pain medicine, have you ever seen these drugs interact in such a way?
I have, but in very rare circumstances, mainly based in my anesthetic practice, when you're giving a lot of these serotonergic drugs at the same time with your anesthetic. And I can count on my hand one instance in the last 20 years where I've seen this reaction, and it was very mild.
So everyone gets so twitchy about serotonin in these interactions, and some people don't get these medications because somebody's concerned that there might be a serotonin interaction, and they don't have the opportunity to perhaps benefit from some of these medications. Now, these are opioid-based medications, so they come with the caveat that opioids have their own inherent risks. Tramadol is considered a weak opioid or opioid-like medication. Tapentadol is a Schedule 8 medication in Australia. So they have their own issues. And I've said it before, Bradley, we will discuss it at some point when you and I have got time to sit down and really dive into opioids. Let's move on to the next group of second-line medications, second-step medications, the patches or the topical agents, which means that these agents are applied locally to where the pain is. Do you use topical agents in your practice, and how do you use them?
Look, I really like topical agents because they're a low risk and can be a high reward in certain patients where they have, as you said initially, Nick, that focal pain. So, I've got an area of burning sensation on my elbow, my knee, and then instead of taking a systemic drug that affects the whole body, use a topical agent
Just use a local drug, yeah.
and you get away with a lot of side effects. So the two ones I tend to use are compounded ketamine cream or compounded capsaicin because we can't get high dose capsaicin in Australia at this point in time.
Yeah, they've got high dose in the UK, don't they? 8%. But in capsaicin in Australia, we can go down to 0.75%, which we can prescribe. Some compound pharmacies will make up to 2%. So it's not 8%, but it's better than nothing. And what about the lignocaine patches? Do you use lidocaine patches?
I do use lidocaine patches. They've come down in price over the years. They're still expensive.
Yeah.
But they can be nice because you can apply a patch. It'll give you a 12-hour duration of action. And it overcomes some of the other issues that you get with the creams is having to apply them regularly. They're a bit messy, and the lidocaine patch you can just slap over the area of that focal nerve pain, and it makes it a lot more logistically easier for the patient if that's a treatment option.
Yeah, and I would as well, if it was me or a family member. I would use a topical agent if I had a small area of pain. Obviously, if it's a big leg or an arm or something, it's really hard to apply the stuff up and down your leg. All right. Ketamine, again, another discussion perhaps for another day, and we can do a deep dive into ketamine, but watch this space. Third line medications. So we've moved from step 1 to step 2 to step 3. And there are two groups here, the strong opioids and neurotoxin, botulinum toxin. In terms of the strong opioid, all I want to say is, like I said before, we're kind of looking down that little bit of a rabbit hole. I don't want to go down there just yet, but opioids are third line medications. They have a significant number of risks. While they might work in the short term, which is what the evidence says, tolerance, dependence, significant side effects can occur. So let's just park that opioid therapy for neuropathic pain. Tell me a little bit about neurotoxin for neuropathic pain. Do you use it? How do you use it? What are your thoughts on it?
So there is evidence for the use of Botox. The problem with Botox is it blocks nerve fibers, which is how it works with nerve pain. And it blocks them on a prolonged period basis, so anywhere between 3 to 6 months. The Botox that you apply to the nerves, if it's a mixed motor and sensory nerve, you're obviously going to induce some muscle weakness in the patient.
So this is Botox that people use around the face for cosmetic reasons, vanity reasons, but of course now you're applying it elsewhere for medical reasons. Okay.
And so one area that we found out is the patients that were getting Botox for facial aesthetics, for reducing their wrinkles, started to report less migraines. And so they started using Botox in migraine treatments where you just inject very small amounts into specific muscles around the face, the back of the head, and neck and shoulders to help manage some of these migraine symptoms.
So this is Botox for chronic migraines. This is Botox into the muscles or the skin, which can help some forms of chronic pain conditions. But I want to point you to Botox on nerves. What are your thoughts about Botox on actual nerves?
So there is an evidence paper about using Botox on nerve fibers, specifically the stellate ganglion, which is a bunch of nerve fibers that originate at the midline of the neck and go out to feed into the face, shoulder, and arm to manage sympathetically mediated neuropathic pain. And it can be very useful in the stellate ganglion because it isn't a strong motor supply. And so you can put a little bit of Botox around that stellate ganglion with other treatments haven't worked to try and treat some facial shoulder pains.
Yeah. I had a patient with ear pain. I know we've discussed this at our consultant meeting. So she had neuropathic ear pain. Lovely lady, absolutely broken by the pain. And we did a number of things. One of the interventional algorithms we went down was focusing on the stellate ganglion. The injection with anesthetic worked. The pulsing with a nerve ablation didn't work. So we tried literally a drop of Botox, and this was about 3 or 4 years ago. It worked for 4 months. Her pain just absolutely vanished. We did it again. It worked for 6 months. We did it again. It worked for 9 months. We did it again. It worked for a year and a half. And I've just seen her recently for that hopefully last injection. Botox is not supposed to work for a year and a half, but it somehow does. And she's a completely and utterly different person now. I would classify her as this is a term, but she's a patient without pain anymore. She does not have pain. She gets it every couple of years, and we treat it with a stellate ganglion Botox injection. Interestingly, she can't swallow for about 12 or 18 hours after the first injection. She has trouble swallowing because a number of other nerves are nearby, but she says, I don't care about that. I am pain-free, so I will accept that difficulty in swallowing for a period of time to start with. this stuff is not governed by a lot of science. So as you've said, we take what science is out there and we apply it to the person sitting in front of us, and hopefully we do it in a manner that is beneficial for the patient with limited risk. All right. So we've discussed the 3 steps, the 3 tiers of medications. I just want to briefly mention that these are just the broad, usual medications for neuropathic pain. We've got ketamine we can use. We've got lignocaine we can use. We've got clonidine we can use. We've got other medications that we can compound into creams. We've got PEA, we got alpha-lipoic acid, we got low-dose naltrexone. Even cannabinoids can be considered in some instances. So there are many other things to talk about, but I just wanted to touch on those 3 big steps of medications. Bradley, I wanted to spend the last 10 minutes or so talking more about how these medications work as part of a package of care, because as you know, and I think we need to tell this to our audience, medications are just medications. They have to be used as part of a broader treatment approach, as part of a broader treatment plan. How do we go about, I don't know, what are your thoughts on that in terms of the use of medications?
Look, I think you're absolutely right. And, pain is difficult, especially chronic pain becomes extremely complex to treat in patients because it affects multifaceted elements of patients' lives. And we're never going to cure patients with one drug, one injection, and it needs to be part of a plan of different therapies together to help the patient move forward and improve their quality of life. So as long as things are put together in that plan format, you've got all of these different avenues that the patient's exploring the same time, looking at diet, lifestyle, exercise, engaging with the appropriate physiotherapist, working on their mental health as well at the same time, combined with the medications or the treatments. And if you're doing just one thing, patients tend to have a low risk, a low probability of success.
Right. So it's like, if I just thought about this, it's like following a recipe. Anyone can follow a recipe, but you can't be a master chef unless you've got that experience, and it's a sprinkle of this and a dash of that. So I'm going to put up on the screen now a picture from a paper, which I'll give you the reference to. And it is that paper you and I discussed this morning, Brady, looking at neuropathic pain and how to utilize these medications in various steps. But side by side to the medications, side by side to the injections, the nerve ablations, the nerve stimulators that we can use to manage neuropathic pain, it's multidisciplinary care. It's focusing on diet. It's focusing on psychology. It's focusing on sleep. Remember, sleep is a massive factor for our patients. And of course, it's making the right diagnosis. It's revising your diagnosis, revising your strategy depending on how things go. One of the hardest parts about what we do is I can give 2 people the exact same medication, the exact same dosing, and they can both have a completely different effect from that medication. And I can't predict how that's going to happen. So it is important to take care. It is important to keep in touch with patients. It's not just a single thing.
Regular follow-up with the patient. And
regular follow-up with patients. It is about testing, learning, tweaking, testing, learning, tweaking. Another one I want to bring up, and again, there will be a link to this, is that French paper, Comprehensive Algorithm for Management of Neuropathic Pain. There are 3 lines and steps, and these are divided into peripheral neuropathic pain and central neuropathic pain. The steps for peripheral neuropathic pain are lignocaine, and interestingly, they've said TENS machine for neuropathic pain. I'm not sure about that. What are your thoughts about using a TENS machine for neuropathic pain, Bradley?
I've used it in a couple of patients with some neuropathic pain with some good results. So
Okay.
it can have its uses, but other patients have used a TENS machine where it's flared up that neuropathic pain, because what they've done is they put the pads in an area of hypersensitivity and then stimulated those nerves directly. and
And
then
they explode. Yeah.
and it's made things worse. So it's a low risk modality on the whole because we're just putting some sticky pads on and introducing some low dose current into the skin,
Yeah.
but it's not for everybody.
No, I don't think it works quite well for neuropathic pain. I'd use it for musculoskeletal pain and certainly quite safe. Okay, that's first line, peripheral neuropathic pain. Second line, peripheral neuropathic pain. Capsaicin 8%, which we do not have, unfortunately. And then Botox, which we've touched on. Fair enough. It's a peripheral focal neuropathic pain. And then third line, they've talked about high frequency TMS, so transcranial magnetic stimulation. And they have talked about strong opioids as third line. And they've also mentioned spinal cord stimulation for failed back surgery, which is a terrible term. It should be called persistent spinal pain syndrome, and diabetic neuropathic pain. Give our audience a couple of lines on spinal cord stimulation for neuropathic pain, please, Bradley.
So spinal cord stimulation, when patients have failed to respond to conventional management strategies, like me and Nick have been talking about, medications, diet, lifestyle, quitting smoking, which I think is a big thing with nerve pain. And there's good studies to show that smokers compound their nerve pain, and not easy giving up, but it can absolutely help with managing your nerve pain, combined with all of the typical medication therapies that we have talked about, the stage 1, stage 2, stage 3. If none of them are helping, then neuromodulation in the form of a spinal cord stimulator has got fantastic evidence behind it for nerve pain. And we have a lot of patients who do very well with neuromodulation therapy for their particular nerve pain, whether it be, as Nick says, failed back surgery, chronic regional pain syndrome, or diabetic peripheral neuropathy, and can reduce the pain, according to the studies, between 50% or more in 80% of these patients.
There are quite a few naysayers out there in terms of neuromodulation and advanced pain procedures.
There are, because this is an expensive therapy, but expense is an upfront cost. And if you compare it to the improvement in the quality of life these patients receive, the fact that then you can manage the pain, you don't have to have them on the medications, they can engage more with the physiotherapy, return to an active life, and enter the workforce again. I don't know about you, Nick, but patients with neuromodulation therapy, I think it's been successful when I ask them, how's work going?
Absolutely, and it's hard to measure the long-term benefits of these therapies because most research goes for 3 months, 6 months, sometimes a year or two at most. But it's expensive to do the research to measure the gains looking forward. And it does. It is an expensive therapy up front. It is a slightly more risky therapy up front. It's certainly no risk like a TENS machine, but then a TENS machine can cause a pain flare. The risk got to be balanced between doing nothing. The risk has got to be balanced between what the patient looks like now and is predicted to look like in the future. So, like I say to healthcare professionals and patients, you've got to have the right assessment, you've got to have the right diagnosis, you've got to try a number of things. The patient's got to be in a good frame of mind, the patient's got to be physically fit to a point, and if you use this therapy by the right people, trained to use this therapy, then it can absolutely be life-saving for patients. All right, second line for neuropathic pain, the French study, peripheral and central neuropathic pain, so not focal neuropathic pain, but central neuropathic pain, so more widespread pain, and that includes arms and legs peripherally. The first line is the SNRIs, which we've discussed, and they mention Gabapentin and the Tricyclics, which is interesting because the second line, they mention combination therapy, which we use a lot of, and then they mention Pregabalin and Tramadol. So they use Pregabalin as a second line therapy, and I wonder because it might have so many side effects.
Absolutely.
And then third line, they've come back to TMS, spinal cord stimulation, and strong opioids. All right, so I think it's time to start winding it up. Just to remember about managing expectations. We're not looking for a cure. We're looking for pain reduction so that patients have an opportunity to focus on the right things like lifestyle, like psychological fitness, like physical fitness. And we're looking for pain reduction of what, 30%, 40%, Bradley, with neuropathic pain medications. Would that be acceptable?
I think that would be very acceptable. A 30% drop to me, provided the patient doesn't have any significant side effects, is an absolute win from these
Right.
medications.
Most patients suffering immensely would take even less of a pain reduction. Not to say that's okay and that's enough, but certainly a good 30% as a start, isn't it? So let's wind things up. A couple of things really. Firstly, neuropathic pain is complicated, and so is its treatment. There is no one-size-fits-all treatment. Everyone's response is different. And I just wanted to say one thing to patients out there suffering with neuropathic pain. Firstly, you've got to make a diagnosis. You've got to get the right diagnosis. Don't give up if the first one or two steps are not working, or if the first one or two medications are not working. It might be the wrong dose. It might be the wrong medication. It might be the wrong combination of medications. And also, before I hand it over to you, Bradley, for your final thoughts, talking directly to a patient that's suffering, it's not about the right drug. It is about the right plan. And that drug medication can be a good part of that plan, but it's about that right overall plan of action. What would you say to somebody out there, Bradley, who's suffering, struggling, watching this video and feels like they've got nowhere to turn?
I would say to them, seek help, because there are absolutely things that we can do to try and help you along this journey and this pathway. And first point of call would be to go and speak to the GP. If it's a good GP, they may try and start you on this pathway on some simple things. And if things aren't improving, there are people who've dedicated their lives and their careers to treating this pain. And they exist, and pain specialists exist everywhere in the world. I'm from the UK originally, so we've got pain specialists in the UK, within Europe, the USA, Australia, and you'll be able to access these services within your area through your local general practitioner, but you have to go in there and ask for the help.
Yeah, you've got to be your own advocate for yourself, unfortunately, in some instances. So let's wrap it up there. If you've made it to the end, thank you for your time. It's much appreciated. Please talk to us down below in the comments. Please subscribe. Please share. Please let us know what you're interested in, what you agree with, what you disagree with, so we can keep this discussion happening. And please keep in touch. Thanks.
Thanks, everybody.